Who in the world had the courage to go on with that? So, welcome to the next episode of Endoscopy Essentials, a partner episode with our sponsor Boston Scientific. And welcome back, Georg Webster. We had this fantastic bio I'm still remembering. And we want to speak about the history of cholangioscopy, where Boston has a great part. I remember when I was young, during an ERCP, when I was a fellow, and Horst Neuhaus said, we need to do a cholangioscopy. There was a deep sigh in the entire room. Oh, no, please not.
Yeah.
And if he insisted, there was a huge build-up and the second person and who is the second examiner. So we really tried to avoid it. Only in cases where somebody thought that's indispensable. You probably remember these times.
Well,
the mother-baby type of thing.
Well, in many ways, I don't, and that's the fascinating story of cholangioscopy, because I think that I cannot think of an area of endoscopy which completely died out and then resurrected. And so, of course, cholangioscopy was first done in the late 1970s, in the 80s. And at that time, this was a fiber optic cholangioscope, was only ever used by the greatest experts. Even then was as you've alluded to, was wheeled out on very rare occasions. And it was a mother and baby scope, a very fragile fiber optic scope.
Huge repair costs, I remember.
Yeah, that needed to be done with two endoscopists. And by the early 1990s, it died a death. I don't think anybody was really using it at all, and in fact, when I started in 1999 or 2000 in my career in ERCP, my mentor Adrian Hatfield at the Middlesex Hospital, really the only cholangioscopy we did was percutaneous transhepatic cholangioscopy, and we had this ancient endoscope with only two-way deflection.
Like a bronchoscope.
I don't think it had any flushing facility, and the views were absolutely appalling. But I don't think we ever used a conventional mother and baby scope. And so, it's a fascinating technological journey, because the initial scopes were available in the 1980s. It completely died out.
Plus, we have to say the complementary imaging methods like MRCP got better.
Yeah.
So there was this feeling, wow, that's all we need. And X-ray here and a pre-diagnostics by MRCP, CT, whatever.
Yes, and it's an interesting point, isn't it? That as we'll come on to discuss, the applications and the use of cholangioscopy has increased enormously, and it's a reasonable question to say, but what did we do in the old days? Which
is a very common question.
Yeah, exactly. Well, in terms of what we did in the old days was, with respect to bile duct stones, we often used mechanical lithotripters, which probably in the early 2000s probably used sort of 5 or 6 times a week in our unit. Now we probably use that bit of kit 5 or 6 times a year. And we failed to clear bile duct stones much more frequently than we do now. Patients came back for procedure after procedure after procedure. But really, it was, I think, 2005 or so when Boston came out with now we call it the SPY legacy. And I think many of us realized immediately that this was going to be disruptive.
But do you know what happened? Who in the world had the idea, now let's revitalize something, which is seemingly dead?
Yeah, good.
Did you issue a need when you spoke to companies like Boston or others and say, hey...
we need this. I think it is... I think that one often doesn't express a need for something if you feel that there's no prospect of it being, materialized. And I think that there was a significant surprise of where did that come from? But that absolutely shifted the whole field. The first single operator cholangioscope.
So somebody must have had some prophetic abilities, or was it just a test thing? And
let's
go into some area. We are not endoscopy makers, but
I think clever.
Also
clever,
single use.
Yeah, clever. And of course it was, I think, probably the first single-use endoscope of any sort in the gastroenterology field. I can't think of examples before that. But I think we realized from the start that this was going to really change things and was going to be very disruptive. And of course, in fact, recently I was looking to do a talk, and I went through my list of images and found best SPY video. That'll be good. I'll have that one. And I hadn't realized that this was best SPY video from 2007. And the visual quality compared with what we're used to now was, so shall we say. But the innovation since then of the digital SPY platform, and then the DS2 and onwards from there has. We've seen both huge improvement in visual quality and I suppose a big step forward in understanding the indications and the based on data and research. And I think we're still not quite there with understanding the where cholangioscopy should be embedded within practice.
That's right. But the interesting thing is when you look at that turning point, so somebody must have had a vision and persistence.
Yeah.
It reminds me, years ago, I heard a lecture from somebody from Siemens who was showing the first MR pictures, which were just miserable.
Yeah.
And I thought, who in the world had the courage to go on with that, which looked just worse than every CT and ultrasound. It was just terrible.
Yes.
It was not that bad here, but to resuscitate something with an okay image quality and, all endoscopies said maybe,
Yes.
Yeah, but go on.
Yeah, and you're right. And also the endoscopists their perception was also negatively coloured by previous experience.
Exactly.
It wasn't that this was just a new piece of kit where everyone's, this is new. People were,
not this one again.
Yeah, we saw this 15 years ago. Please, we've had enough of this.
I think you have some slides which nicely summarize.
Yeah. And this is kindly donated to me by Boston Scientific, and this slide starts well before Boston Scientific were involved, back in the 1970s, and the mother and baby, but the innovation since then has been extraordinary, and the incorporation into clinical practice. And so within our our unit at University College in London, we're doing now up to 200 cholangioscopies a year. All I think for strong reasons. We're not using cholangioscopy for 6 millimeter bile duct stones. Clearly, we have a referral bias of the patient sent to us. But I certainly do look back on how we managed patients in the past, and reflect on, without having cholangioscopy, there were patients being sent off for very high risk surgery, surgical exploration of intrahepatic ducts, and actually the surgical management of Maritzi syndrome, quite a common problem. We now recognise that surgeons hate operating on Maritzi syndrome because the patient just thinks they've got a gallstone, it can be removed, but that surgery can be very, very difficult, and cholangioscopy can revolutionise the management of Maritzi syndrome. And I think we're going to see lots of innovations on from here. Boston, new cholangioscopes from them, the Savita cholangioscope, which is providing a scope with different external diameters, standard 11 French, but also 9 French, which is really allowing us access to the pancreatic duct and intrahepatic ducts. We'll see where AI, impacts on the field. We're certainly not there yet, and I think that the ability to get bigger biopsies with the newer cholangioscopes is going to have a bigger and more immediate impact on diagnostics than AI. But that may be the way we're going.
So one of my tasks as interviewer is to grill my interviewees a little bit. So two different areas, stones.
Yep.
I think everybody agrees it was a breakthrough.
Yep.
Yeah. By the way, how many of you 200 something cases are stones? Half or less, or
no, probably more than half. Probably 65% are difficult stones.
But then let's focus on the stricture type of thing, the imaging thing, where all the AI comes in. I think that's still a difficult area.
Yeah.
Because there's something like a pretest likelihood, and if somebody comes where you think this could be a cancer, is there what would you require now or in the future that cholangioscopy really changes it?
Yeah, what we would require,
especially away from surgery or chemotherapy or
what we will require is tissue. We and others have worked hard on visual assessment of strictures, and I think to be honest, and our the work by ourselves and others, and the presumptions about visual characteristics that are diagnostic of malignancy. Abnormal blood vessels, nodularity, ulceration, etc. They simply are not reliable enough, particularly in the patients who are most difficult to make a diagnosis in. The patient with primary sclerosing cholangitis. You do a cholangioscopy in those patients, and many of the biliary mucosa looks like terrible small bowel Crohn's disease. And anybody who says that they can confidently distinguish benign or malignant in that setting, well, they're better than me. Will AI help? One of the problems with AI is that one needs a ground truth.
Yes.
And you need huge amounts of data. And of course, in colonoscopy, we can look at a hypoplastic polyp and we can say that's hypoplastic, and we can take it off and we can prove it's hypoplastic. much harder building that data in cholangioscopy.
It is like an IBD, where there might be a lesion and 5 millimeters right to it, it's inflammation. And you have to make sure where the biopsy is from and the image correlation. So that's a long way to go. But in your current practice, if you have a patient, I mean, it's mostly hilar strictures, right? The distal strictures are perhaps easier, and you think that could be malignant. How far do you go before you do not send the patient to, let's say, surgery?
Yeah, I think that increasingly what we're trying to do is what I would call front load the investigation. You know, we all recognise that we can have enormous diagnostic delay in these patients. They come up, they have an ERCP, you take a brush, the brush is negative, you review that in a meeting a week or two later, then you decide, oh, we'll do this. And before you know it, 2 months or even more down the line, you're still doing various investigations. What we increasingly are doing is doing everything we want to do at the first procedure. And so
early on cholangioscopy.
Early on, we're very comfortable doing cholangioscopy at first ERCP. And of course, if you're going to make any visual assessment, you're much more likely to be able to make it before there's been a stent in. And, you know, we want to do ERCP with biliary cytology, perhaps endobiliary biopsies, definitely cholangioscopy and targeted biopsies. And then with all the necessary cross-sectional imaging, MRCP, CT, maybe a PET scan, we want then to present that, you know, as a block to the multidisciplinary meeting, to the surgeons and the oncologists, and say, look, this is where we're at. You know, now is the time to make the decision. And of course, our oncologists certainly, and increasingly our surgeons, they want a tissue diagnosis before proceeding.
So, George, I think it even gets worse because in many cases it was surgery or not. And if you were operating on a seeming tumor, which was inflammation, it might have been a massive overtreatment, but not a wrong treatment. Now we have neoadjuvant options. And we have to, in the future, we will need which one. So again, tissue will be the issue even more, right?
Yeah. No, I think that's absolutely right. And you know, we've all been involved in the care of patients who have had what proved to be unnecessary major surgery. We've also been involved in patients who everybody has said this is bound to be cancer. They're no good for an operation, so let's put in uncovered mesh metal stents across the liver hilum, and then
patients live for years.
And it never was cancer. And then we've recently had 2 patients who have needed liver transplants for IgG4 related disease, almost specifically because of having uncovered mesh metal stents in place. And so if cholangioscopy and tissue acquisition can prevent that by giving us not just is it cancer or isn't it cancer, but no, it's not cancer, but we've got good tissue to say this is, for example, IgG4 related disease, and then can go on to steroid therapy or other medical therapies. So yes, I think that despite the really important advances in cholangioscopy in terms of visual quality, I think its role as a platform for targeted biopsies is going to remain incredibly important.
Whatever AI will do, I think when we don't know what to do, we call for AI. Let's see whether it helps, because it's then the subgroup of very difficult cases, right? Yeah. And that's a different challenge from differentiating the obvious cancer from the obvious benign disease. But we will see. So for the future, what is your major hope for the further development? It's tissue, or
I think tissue acquisition is going to be important. I think new approaches to getting tissue. There's a big drive to having bigger working channels so that we can use bigger biopsy forceps, but there may be other innovations. Is there a role for a punch biopsy, a true cut type biopsy? At EUS, we biopsy through the wall of the bile duct from the outside. One of the challenges of biopsying at the moment is we get such superficial tissue. So will new modalities to acquire tissue help us further forward? I think that one of the things I think that will change, and in fact I've been involved through the ESGE curriculum and quality improvement group in trying to see where cholangioscopy will sit in people's practices. And you gave the example many years ago of cholangioscopy sitting only in the hands of the most rarefied super specialist. When spyglass was developed, it nevertheless sat within and only within specialist units, which is always how these things develop. But increasingly, we recognise, and this ESG document soon to come out, is looking to define what we might call basic cholangioscopy versus advanced cholangioscopy. So basic cholangioscopy, the management of extrahepatic bile duct stones, the assessment of extrahepatic biliary strictures, really that should sit within the skill set and within the infrastructure of a unit delivering, reasonable volumes of ERCP. Advanced cholangioscopy, intrahepatic stones, intrahepatic strictures, pancreatoscopy, will need to sit within specialist centres. But I think the cholangioscopy over the next few years will come to be seen as a standard part of biliary disease diagnostics and therapy.
That sounds like a conclusion. We certainly agree for stones. There's more work to be done in the stricter diagnostic area.
Yeah.
We could also hope for tissue processing progress, that we may need so much tissue, maybe from multiple spots, but it's a fascinating area. I'm very grateful, George, for this nice session, and we'll be back with our basic cholangioscopy course in the future.
Very good. Thank you very much.
Thank you.
Thank you.